Hello everyone. So finally the INICET results have been out, and congratulations to everyone who have done really well, and those who have not, don't be that depressed. Picture abhi baki hai, so just buck up. You have a very big exam coming up, but that is NEET. So why we are here today? Because everything which was asked in INICET, that topic is a very good potential question for upcoming NEET. So we are not here to discuss only the answers. You all must be having answers by now. We are here to discuss the topic as a whole, so that if a repeat question is being asked on that topic, we don't miss it, right? So let's start. So the first question was, all the following are features of a normal term placenta except one. Diameter is 22 centimeter, placental thickness is 2.5, weight of placenta is 500 gram, or it is a two-vesseled umbilical cord. So it was an easy question. We have taught that in the videos also. So this is from one of my videos, so where we discussed that placenta, those of you who have not seen a placenta, or maybe have not taken the placenta in your hand, you can feel it is like that of a football. The size is like that of a football actually. So the diameter is similar, 20 centimeter, but since it is not a football exactly, it's not spherical, it's a disc-like structure, the thickness is 3 centimeter, right? So the size is 20 centimeter, size is 20 centimeter, but thickness is 3 centimeter, and weight is also like that of a football. So weight is 500 grams. You can also remember by a way that, feto-placental ratio is 1:6. So if an average fetus which is being born to a mother is 3 kg, the placenta has to be 500 grams. That makes it to be 1:6, right? So these are the features of a placenta. This is the size, then the thickness, and the weight. Okay, let's get back to the question. So our question said diameter is 22 centimeter, that's correct. Thickness is 2.5, correct. Weight is 500 gram, that's also correct. Is it a two-vesseled umbilical cord? No, it is three-vessel umbilical cord. So it has two arteries and it has one vein, which left vein is there. So we used to remember it by the way that one is left. So it is not two-vesseled, it is three-vesseled. The two-vesseled umbilical cord means single umbilical artery. When it happens, it is pathological. Single umbilical artery has also been asked in the question. Single umbilical artery is the most common umbilical cord abnormality with an incidence of almost 1%. Seen in case of renal anomalies, in case of cardiovascular anomalies, and in case of trisomy 18. Not in Downs, in trisomy 18. In these cases, and in case of maternal diabetes mellitus. These are the very common anomalies in which the single umbilical artery is seen. This is also has been asked previously, right? Okay. Next, which of the following suggest primary amenorrhea? 14-year girl with breast tanner 5, 11 with breast tanner 1, 13 years with breast tanner 5, 14 years with breast tanner 1. First thing, that everything beyond tanner 2, if the breast tanner is 2 and beyond, it means now the breast has started getting the secondary sexual characters. Less than 2, it means 1, is not a breast who has been exposed to estrogen. Okay, a normal breast bud, that is tanner 1, is not a secondary sexual character. So tanner 1 is indicating that breast have not developed at all. Now important is to discuss the age limit. You must have seen at some sites the age limit is 14 and 16. And at some sites it is 13 and 15. What should be the answer? I tell you why it is there. So previously this age limit was 14 years and 16 years. It used to say that anyone who has no secondary sexual characters are not there, should be called primary amenorrheic after 14. In case secondary sexual characters have developed, you can wait till 16 years, and if she does not get menses even at 16, you will call it primary amenorrhea. So this was the initial definition. Okay, but then now it was eventually seen that as we have discussed also in physiology, that when you are staying in an affluent area and good nutrition is there, the age of puberty tends to fall down. So girls who are in a flourished environment with good diet and nutrition, they tend to have menses earlier comparatively. So this was eventually by the American guidelines dropped to 13-15 years. Okay, so now according to them the age is not 14, it is 13. Here it is not 16, it is 15. So some books have changed it, but some good reference books have not changed it. So what will be your answer? So for that confusion, I checked the Indian guidelines. So whenever there is confusion, your Indian guidelines come to rescue. So FOGSI, which is Federation of Obstetrician-Gynecologist Society of India, released a paper not very far back. In 2021, they released their paper on primary amenorrhea, and there the definition was 14-16. So the Indian guidelines have not made this change. Okay, for Indian girls, still the definition is 14-16. Any girl who has not got secondary sexual characters at age of 14, or any girl who has got secondary sexual characters but not having menses till age of 16 is called primary amenorrhea. Okay, come back to the question. So 14-year breast 5, she is fully developed breast. 11 years breast is not developed, but 11 years is too young. 13, breast tenor 5, breast is fully developed. 14, breast tenor 1. Yes, so 14 years, no secondary sexual characters. This is your answer. So remember this, your limit is 14-16. 13-15 is not wrong, but for Indian guidelines, it is wrong. Right? Okay, I hope you're not confused. This is your age limit in India. All the following are features of sorry, so the question was wrong, I think, yeah. So this question was, so there were features were given saying the girl has primary amenorrhea. Sorry, the wrong question has been typed. I hope nothing has been typed in. Yeah, so the patient girl was having primary amenorrhea with webbed neck, right? She was having webbed neck and short hairline. Okay, short hairline was there in the question, and the hormonal profile was given, which said that E2 is low, whereas FSH and LH are high. So this was the question. The diagnosis was being asked. One additional thing was given, that on ultrasound she had streak gonads. Now she does not have secondary sexual characteristics. She has streak gonads. She is clearly a case of gonadal dysgenesis, right? Streak gonads with no secondary sexual characters means gonadal dysgenesis. What exactly is gonadal dysgenesis? Basically, when our gonads do not form, the stroma contains no follicle. It contains only the fibrous tissue due to certain genetic conditions. It is called as gonadal dysgenesis. It is the most common cause of primary amenorrhea. Most common cause. So if a girl is not having secondary sexual characters and she is not having her menses, this is the most common cause. Now, gonadal dysgenesis can be due to a lot of genetic conditions, which is, one of them is Turner's. Then there can be pure gonadal dysgenesis XX. There can be XY gonadal dysgenesis. They all can lead to gonadal streak gonads. Most common cause among them is Turner's. So Turner's is the most common cause of gonadal dysgenesis. Okay. Now, basically, let's see how you evaluate a patient when you get a patient of primary amenorrhea. So when you get a girl of primary amenorrhea, what do? You want to see that, okay, she does not have got her menses. Whether she has been exposed to estrogen or not, how will you know? So the best marker for estrogen exposure is actually the breast development. So you will see breast development is present or breast development is absent. So breast development absent means she has not been exposed to estrogen. If she has not been exposed to estrogen, so either there is problem in the center or there is problem in the gonads. So what will you do? You will get the hormonal profile. You will get E2, you will get FSH, you will get FSH and you will get LH. Okay. In case, so just I want to pause. So you will get these three hormonal profiles. Okay. Now your E2 will be low. Okay, because she has no breast development. If E2 is low but FSH and LH are high, it means the center is normal. Your HPO axis is normal. Your gonads are not working. That is why on the center there is no negative inhibition. Okay, and since it is working properly, FSH and LH level are high. So there is a problem in the gonads. Okay, but suppose if the FSH LH is low, then you know, okay, that is why my estrogen is low, because my center, the hypothalamus or the pituitary is not functioning properly. In that case, you will get an MRI. Here in gonads, you will get the what? So it is a case of most likely gonads not functioning properly, you will get the karyotype. Okay, because karyotype will tell you which type of gonadal dysgenesis is there, right? So here also the condition given is this: E2 is low, FSH LH is high. Case of gonadal dysgenesis, now let's see what another information is given to us. They have given us that it has webbed neck and short hairline, right? So what it is there? It is clearly indicating this is a case of Turner syndrome. Kallman syndrome is a problem where there is improper migration, neuronal migration at the hypothalamic level. So it's a central problem. As a result, what will happen in Kallman syndrome? The FSH and LH are low. Secondary sexual characters are not there, but FSH, LH are low. In androgen sensitivity syndrome, so basically androgen sensitivity is an XY person who are insensitive to this androgen. That is why the FSH, LH is not a problem. It's not a hormonal problem. FSH, LH are normal, right? But the testosterone is high. It's actually a male person. And the breasts are developed. That's what we have discussed in androgen insensitivity. Breasts are developed, but pubic and axillary hair are absent. That is typical of androgen sensitivity. If it has been given that breasts are developed, but pubic and axillary hair are absent, you will think of androgen insensitivity syndrome. Okay, and why breast is developed? Because this high testosterone goes in the periphery to and get converted into estrogen. MRKH, the karyotype is normal, but there is no uterus and vagina. So hormonal profile is normal. Secondary sexual characters are normal. It's just that they don't have uterus, vagina, so they don't menstruate. Okay, so that is why they are not the options. So what is given in Novaks of Turner? That features of Turner clearly indicate that they are short stature, there is absent sexual development, webbed neck, low set ears, posterior hairline, widely spaced nipple give it appearance of shield chest, short fourth metacarpal and an increased carrying angle. They all are the features of Turner syndrome. Okay. So there is no mental retardation. So mental development is normal. Can you see here? There is no problem in the mental development. IQ might be little low, but as such, the patient does not have that problem with the IQ. Okay. Next, all are the causes of uterine dysfunction except. So, is it high fetal head, multiparity, neuraxial block or chorioamnionitis? Let's see. So, this is uterine dysfunction basically is a cause of the dystocia of abnormal labor. Now, uterine dysfunction can be of two types. Hypotonic is a more common one in which basically there is a regular wave pattern uterine contractions with fundal dominance. So, they are good, but the intensity is very low. Intensity has to be more than 25 millimeter of Mercury for cervical dilatation. So intensity is low. That is why dilatation does not happen, dystocia happen. Another type of uterine dysfunction is hypertonic or incoordinate. So either the tone is very high or it is not in a wave pattern. Okay, it's not in a wave pattern. It's like something like this. It is less common, but it can also lead to dystocia. Now the causes which lead to uterine dysfunction have been listed in New Williams, which clearly says that right, high fetal head. So any kind of obstruction in the pelvis can eventually lead to uterine dysfunction. So if there is uterine dysfunction occurring, if the uterus is not contracting properly, you are giving oxytocin, but still the contraction is not happening, think that there might be obstruction. Pelvis might be contracted or the baby might be big. Because if the uterus is trying to push the baby and there is no space to go down, the uterine malfunction starts happening. So obstructed pelvis, high head is a common cause of uterine dysfunction. Another is either a general anesthesia or an epidural neuraxial block. They both can lead to uterine dysfunction and they both can lead to delay in both first and second stage of labor. So remember, first and second stage both can be delayed by these. Okay. Then infection, chorioamnionitis is a very well known cause, but not multiparity. In fact, nulliparity, a brother who has never been exposed to labor, is one of the cause of uterine dysfunction. So this is our answer. All the following are features of abruptio placentae except. Very commonly asked question and very easy one. Is it uterine tenderness, warning hemorrhage, painless bleeding or enlarged uterus? What it is? Obviously, it is painless bleeding. Painless bleeding is a sign of placenta previa, not abruption. Let's know a little about abruption. So, what is abruption? It is the premature separation of placenta which is normally situated. So, it is important that placenta is normally situated. It is not low-lying. But before labor, before its time, it gets separated from the uterus and leads to bleeding. It can be of two types. Either the concealed which is less common, So it can be revealed or it can be concealed. So revealed is more common, in which the blood, in abruption, what is getting ruptured? In abruption, the decidual spiral arterioles are getting ruptured. Okay, these are getting ruptured. So sometimes in revealed, the blood seeps through between the membranes and comes out, and you can see the blood coming out, the dark color blood. Okay, but in concealed, a hematoma forms behind the placenta. The blood doesn't come out, it keeps getting collected. It is less common, but it is more dangerous. Why? Blood keeps on getting collected, you will not know, and placenta will be completely separated. Another thing, since the blood is getting collected due to high thromboplastin, it is a very big risk factor for development of DIC. So concealed hemorrhage is more harmful than revealed one. Okay, how the patient will present? Clinical features are typically patient will have pain abdomen with dark bleeding. Okay, that is typical. Patient will have pain. Almost 60% of patient will have abnormal fetal heart. Abnormality in fetal heart will start showing on NST. Okay, there will be maybe a history of trauma will be there leading to abruption, or a history of hypertension will be there. Okay, so painful bleeding, uterus will be contracted. The tone, obviously a hematoma is being collected, so uterine tone will be high. So uterus will be tense and tender. Okay, it is not painless, not at all. One other question asked is, the blood which is being collected or revealed, whose blood it is? It is maternal or fetal blood? So decidual spiral arterioles are basically maternal. So it is the maternal blood which is being collected in abruption. Right? Okay. So this is about the abruption. Another thing which can be asked is a risk factor for abruption, which is most important: prior abruption, increased age and parity, preeclampsia, hypertension, infection. Premature rupture membrane is a very common cause of abruption. Multifetal gestation, low birth weight, cigarette smoking, you should remember, and cocaine use. They are the commonly asked questions, that they are the risk factors for abruption. Let's get back to the question. We know it is the painless bleeding, which is not there in abruption. What else can be asked in abruption? Diagnosis of abruption, I want to tell you, is basically clinical. Many times you are not able to see the hematoma on ultrasound. MRI can help you in diagnosing abruption, but generally the diagnosis is clinical. Okay, so clinically, fetal heart is not normal, uterus is tense and tender, then you have to deliver. The management is deliver the baby. Otherwise, you will land up in having IUD and mother having the DIC. Okay, so the management is deliver and the diagnosis is clinical. Sometimes what is asked that what are the signs of severe abruption? So severe abruption basically is not depending on how much blood has been there. That you cannot know. Severe abruption is based on the sequelae in mother and baby. So mother having DIC, shock, or having transfusion, renal failure, they all indicate that your abruption was severe. Similarly, fetus, in which there is abnormal heart rate or fetal death or restriction, is again indicating a severe abruption. If the baby has been born safely, then preterm delivery or growth restriction are a sign of severe abruption. It is important to know that your abruption was severe. Okay. Next question. What is the correct sequence of steps in active management of third stage of labor? Very, very commonly asked and repeatedly asked, and the most confusing one. So the question, it had 4 options: uterine massage, uterotonic, control cord traction, and check for second fetus. Now we have taught this, that active management of third stage of labor according to WHO 2018. What WHO did in 2018 is it said that there are 3 steps in active management of third stage of labor, and it said that these 3 steps has to be prioritized. So the first step is the most important step, which is your uterotonic. So uterotonic is your first and most important step. So it prioritized its steps. Uterotonic has to be given in all within the delivery, within few minutes of delivery of baby, and the first choice is oxytocin, either IV or IM. Both can be given in active management according to WHO. If oxytocin is not there, go for methergine or misoprostol. Okay. Next step is the second most important step, is control cord traction. You put one hand on your fundus, you put another hand on cord, and you do control cord traction during the uterus is contracting. Once uterus start contracting, you will do control cord traction. Always done when there is a skilled birth attendant present. Otherwise, it is not done. You can lead to uterine inversion. This was the second most step. Third was not uterine massage. So it was basically uterine vigilance. So uterine tone assessment. Repeated uterine tone assessment is the third step of active management. Plus minus massage. Why plus minus? Because if the tone is less, you will massage. If the tone is good, you will not do massage. So massage is not a profile axis for PPH. Okay, if the tone is good, you don't need massage. Uterine tone assessment is a better term for active management. The fourth step I have written, delayed cord clamping, is something which you have to do in third stage of labor. It is not a step of active management. So purpose of active management was the PPH prevention. Okay, that is why these three steps were given. This delayed cord clamping as such has no role in PPH prevention. Delayed cord clamping has to be done in all the patients who are in third stage, but it is not part of active management of third stage. So you're getting my point. Active management includes only 1, 2 and 3. Right? Now here a new option was inserted, which was the check for second fetus. So before giving oxytocin, you will always keep your hand on the uterus and check whether there is a second fetus or not. Because if it is there, you will not give the uterotonic. Okay, so check for second fetus is always the first step, and it is also given in the WHO workbook. Okay, so it's not a random answer. First check for second fetus, then give uterotonic. It is given. So answer has to be 4, then uterotonic, then controlled cord traction, and in the end uterine massage. Okay, not uterine massage. It should be actually, if it is given uterine tone assessment, it is a better word. Okay, so it is 4, 2, 3, 1. Okay, right. Which of these is not a long-term reversible method of contraception? Very easy. So long-term reversible method of contraception involve hormonal implants. Correct. Sterilizations. Is sterilization reversible? No, it is irreversible. So it is not a long-term. It's a long-term method but not reversible. Injectables, yes. Intrauterine device, yes. So WHO basically divides its contraception into high efficacy, mid efficacy and low efficacy. So high efficacy basically involves sterilization, it involves implants, and it involves IUDs. Mid efficacy is your OCPs, and low efficacy is your barriers and your fertility awareness method. So this is how WHO divides its contraceptive methods. So basically long term is those who can be those in which the repeated doses every month is not needed. So long acting reversible contraception involve the IUDs and implants, but injectables are also inside them, because injectables have to be repeated every 3 months. So they are also long acting reversible contraceptive methods, right? A patient who is 35 weeks 5 days has been brought up with complaints of altered sensorium. Her BP is 170/110, 3 plus proteinuria, 3 cm dilated, 50-60% effaced. What will be your next step? She is 35 weeks 5 days. She is high BP with high proteinuria, so she is severe preeclampsia. Okay, severe preeclampsia because proteinuria is also there. So basically what they are asking is, what is the management of severe preeclampsia at this gestation? That's what they want to know. They want to know whether you know or not that when do you have to terminate a pregnancy with severe preeclampsia. Okay, so let's first of all see the preeclampsia. So this has been taken from the recent ACOG guidelines. What is the diagnostic criteria? You know that BP more than 140/90. That BP more than 1. What is happening? You know that BP more than 140/90 4 hours apart. If BP is more than 160/110, then you don't have to wait for 4 hours. Within short time you will repeat. If this is there after 20 weeks, see, listen, after 20 weeks it is preeclampsia, but there has to be proteinuria. So high BP with proteinuria after 20 weeks is preeclampsia. But in absence of proteinuria, in case the proteinuria is not there, then in pregnancy new hypertension with any of the following features, which is thrombocytopenia, renal dysfunction, liver dysfunction, pulmonary edema, or the BP is not getting responded to the normal medications, then also it is preeclampsia. So proteinuria should not be always there. Okay, it is not that proteinuria has to be there. If the patient has high BP and these severe symptoms, then also it is preeclampsia. First thing I wanted you to know that. Then another thing which is being asked is, what is preeclampsia with severe features? Now first, then you have to differentiate your preeclampsia into mild, moderate and severe. Okay, so preeclampsia with severe features are either the BP is 160 by 140 on 2 occasions, again 4 hours apart if BP is that high, or there is thrombocytopenia, or there is impaired liver function. Okay, if there is impaired liver function or renal insufficiency shown by high creatinine levels, pulmonary edema, or the patient has cerebral symptoms like headache and visual disturbance, then also it is severe preeclampsia. It does not include any of the fetal features. Oligo is not there, IUGR is not there. So all the maternal symptoms of thrombocytopenia, abnormal liver test, renal insufficiency, they indicate severe features. Why do we want to know severe features? Because management is different. So what the guidelines said, they have taken it from here, that there are no randomized trials suggesting that without severe features you should continue monitoring till 37 weeks. So without severe features you can wait till 37 weeks, but the patient will need to have an inpatient care. You have to admit the patient and you have to repeat her weekly blood test. Why? Because you want to see whether she is going into severe features or not. So you will do weekly blood test and you will do weekly fetal monitoring by either a biophysical profile or a NST. So you will keep monitoring them, you will admit them and you will try to stretch them till 37 weeks in case of mild preeclampsia. In case of severe preeclampsia, like in this one, in case of severe preeclampsia, the termination age is 34 weeks. Okay, any patient with severe preeclampsia at 34 weeks, you have to terminate the pregnancy. If she is very advanced in pregnancy, then only you will go for normal labor. If not, she is a severe preeclampsia patient, she can anytime land into eclampsia or HELLP syndrome. You will not wait for induction of labor. If she is in early labor, you will straight away go to cesarean, right? What about before 32 weeks? Before 34 weeks, you will try giving her antihypertensives, you will try giving her anticonvulsant, and you have to do very strict monitoring with daily blood levels. Because if the hypertension does not resolve or her blood levels become severe, then at any gestation you have to terminate. Okay. So basically the treatment of severe preeclampsia is 3-tier. You have to give antihypertensive in all. You have to give Magself for anticonvulsion in all, and you have to deliver. So the treatment of preeclampsia is delivery. Before delivery, the preeclampsia cannot be corrected. You just have to wait till you reach an appropriate gestation. Okay. So antihypertensive, yes, you have to give anticonvulsant in all, and you have to deliver. Since she is 35 weeks 5 days severe preeclampsia, we have told you after 34 you terminate. The answer is Magself, management of hypertension and termination. Okay. Steroid she does not need. Tocolytics you will not and deliver at 37 weeks. This will be the case if she is a mild preeclampsia. Conservative management is the same. They are same. They have to be done if she would have been mild. Okay. So our answer is D. Yeah. So same, first sign of Magself toxicity is hypotension, loss of knee jerk, tachycardia or decreased urine output. So see, basically Magself is very important, you should know. It is again the treatment of severe preeclampsia, treatment of eclampsia, and also in case of neuroprotection. Okay, if the baby is neuroprotection, if the baby is less than 30 weeks, okay, then also you give Magself. So Magself regime are 3. Pritchard is an IM regime and Zuspan and Sivai are the IV regime. So here you are giving Magself IM. The first initial dose has to be given IV in everyone, then the continuation dose has to be IM in Pritchard. Whereas in Zuspan Sivai, the continuation dose, the maintenance dose is IV only. So these are 3 different regimes. Important is when to know the Magself toxicity has started happening and how to monitor. So the therapeutic levels of Magself which should be there for the anticonvulsive effect is 4 to 7 milliequivalents. So 4 to 7 milliequivalents per liter is the therapeutic dose unit. If your level extend beyond that, then Magself can lead to toxicity. At 10 milliequivalents, it can lead to loss of patellar reflex, which is the sign of impending toxicity. So it is the first sign that toxicity is about to happen. Okay, beware. So at 10 milliequivalents, loss of patellar reflex. At more than 10, slow breathing. At more than 12, respiratory arrest can happen. And at 30 milliequivalent, at such a high dose, cardiac arrest can happen. Okay, so it is that dangerous. Okay, so this is the signs which can appear eventually if the plasma levels are more. So how will you monitor? So for monitoring the max self toxicity, you need three things. Obviously, the first sign of impending toxicity is no loss of knee jerk. So you will monitor using, So you will monitor using patellar reflex. You will see the patellar reflex in the patient whom you are giving max self. Then you will look for respiratory rate, because next thing which happen is slow up breathing. So you will look for respiratory rate, and also you will look for urine output. Why are you looking for urine output? Does it cause fall in urine output? No. So decrease in urine output, oliguria is not a sign of max self toxicity. But if the oliguria is being happening, because she's a preeclampsia patient, she can have renal failure. In case oliguria is happening, the toxicity will rapidly occur. So in case oliguria is there, you have to reduce your dose of max self. That is why you look for urine output. Okay. So the signs are these two. These three are used for monitoring. And how do you treat? You treat using calcium gluconate or calcium chloride 1 gram. First, stop the max self and give calcium chloride or calcium gluconate. Okay. So let's go back to the question. First sign of toxicity, hypotension is not caused by max self. So max self is not an antihypertensive, not at all. It is loss of knee jerk. Tachycardia, no. Decrease in urine output, no. Okay. Identify the placental abnormality by the given image. So I'm not very clear what was there, but as the students have told me, it was something bilobed with the cord attached on the membranes. So the answer will be either succinturate lobe, succinturate with filamentous cord insertion. So this was the answer. So let's quickly revise the placental abnormalities which could be there. So basically, placental abnormalities could be many. Like this is a filamentous cord insertion. So when your cord is attached on the placental membranes instead of on the placental mass, it is filamentous cord insertion. Okay. The cord is not attached to the center. As such also, cord is never attached to the center. It is always paracentric. But if the cord is attached at the membranes, it is filamentous cord insertion. If the cord is attached here at the very corner of the placenta, it is battledore placenta. It is battledore placenta. When the cord is not on the membranes, it is on the placental mass, but at the periphery of, like a badminton. Okay, at the periphery of the placenta, it is called as battledore placenta. Succinturate lobe. So how to differentiate bilobe and succinturate lobe? Bilobe, the size of the placental lobes are almost equal. When the size of another lobe is very small compared to the main placental mass, it is the succinturate lobe. Okay? Right? And succinturate lobe is clinically important because when a vessel is connecting the main placental mass and the succinturate lobe, like here, it can very easily cause vasa previa. Okay, if this vessel is passing through the cervix, it can cause vasa previa. So it can lead to vasa previa. Sometimes whole placental mass is removed, but the lobe is left behind. It can lead to PPH. It can lead to subinvolution. That all can happen with the succinturate lobe. Another abnormality of placenta is the extracorporeal placenta. Extracorporeal is, see, placenta has two plates. One is basal plate of mother. One is chorionic plate of the baby. They are almost of equal size. What happened in extracorporeal? That chorionic plate, the plate of the baby, becomes smaller. As a result, there is infolding of the membranes. Now, when there occur infolding of the membranes, there occurs hematoma collection, which leads to thickening of the margin. Okay, thickening of the margin because of the hematoma. And since the chorial plate is small, the vessels of the chorion abruptly end near this margin. Okay, so this is circumvallate placenta. This is circumvallate placenta, which is clinically important because it can lead to abruption and PPH. It can very well lead to that. So it is a clinically important abnormality in which there is a thick rim and the placental vessel, the fetal vessels abruptly end near this rim. Now similar extracorporeal placenta is when again chorion plate is smaller, but there is no thickened rim and the fetal vessels do not end abruptly. So it is a minor form of circumvallate, is circummarginate. And circummarginate is not clinically important, right? Okay, so these are the placental abnormalities. Next, Which of the following is not a component of biophysical profile? So biophysical profile, also called as Manning's score, based on the scientist who gave it. So Manning saw that there are 5 fetal variables which can tell you the fetal health. So those 5 variables were non-stress test, means the fetal cardiac activity, fetal breathing movement, fetal movement. So fetal breathing rate, it's not fetal breathing rate, it is fetal breathing movement. When you see 1 episode of breathing, that is enough. Fetal movement, fetal tone means 1 episode of extension followed by flexion again, the fetal tone, and the amniotic fluid volume. So these 5 features were described as the Manning score, and each variable was given a score of 2. So the maximum score is 10. Okay, so when the fetal is healthy, these variables are in a good health. The score will be 10, or maybe 8 by 10 is a good score. Okay, so our question was, which of the following is not a component? Amniotic fluid, it is. Non-stress test, it is a component. Fetal movement count, yes. Fetal respiratory rate, no, it is not fetal respiratory rate. It is a fetal respiratory movement. You just need 1 respiratory movement for your biophysical profile to give you a good scoring. Okay, right. So this is the beat fetal biophysical profile done in case of a at-risk fetus and started at almost gestation of 32 to 34 weeks. So in case of severe conditions, in high-risk condition, they started at 32 to 34 weeks. Okay. Now, modified biophysical profile has been there since it takes a lot of time to calculate whole biophysical profile. Modified biophysical profile contains only 2 things, and a question has been asked on that. Modified biophysical profile contains only the amniotic fluid volume and the non-stress test. So when NST and amniotic fluid volume, only 2 segments are used, only 2 features are used, it is called modified biophysical profile. Now the question has been asked on interpretation of biophysical profile. So if it is, the score is 10, good, you have to do nothing. If the score is 8 by 10, then also it is normal, not a problem. Problem arises when the score is 8 by 10, but the variable which is causing this low score is the amniotic fluid volume. So amniotic fluid volume is a very important variable in biophysical profile. If the score is 8 by 10, but your amniotic fluid is normal, no problem. But same 8 by 10 score with low amniotic fluid, basically amniotic fluid is less, it is a case of chronic fetal asphyxia. You have to deliver the baby. It is that important. If your score is 6, now everything below 8 is not normal. So if your score is 6, then it is possible fetal asphyxia. In case the baby is mature, it means baby is 36 weeks. So 6 by 10, if baby is 36 weeks, why wait? Baby is mature, just deliver the baby. But if the baby is less than 36 weeks, what will you do? You will repeat the test. In case you repeat and you find it is again 6, please deliver. Okay, don't wait for this baby. 4 is again a very bad score, so you will repeat the test same day. And if it is again less than 6, it does not need to be 4 again. If it is less than 6, you have to deliver. 0 to 2, you have to deliver. Okay. Next question. Which of the following signs of pregnancy will be seen at 8th week of gestation? Right. Osiander's sign, Goodell's sign, internal ballotment, lightening, or engagement. So let's go for the signs of pregnancy. So signs of pregnancy could be early, mid and late. So early pregnancy signs are always seen in the pelvis. Obviously in early pregnancy, the fetus is within the pelvis. It has not come in the abdomen. So major of signs are the pelvic signs. First is Jacquemer or Cadwick sign. So basically due to increased vascularity, your vestibule and vagina become bluish, dusky hue. That is the Jacquemer's or Cadwick sign seen at the 8th week. Osiander's sign is that you can feel the increased in pulsation through the lateral fornix. So when you insert your finger in the lateral fornix, there are increased pulsation. Because why? Because the blood flow to the uterus starts increasing from the uterine artery. That is why you feel increased pulsation at 8 weeks. Goodell's sign is soft cervix. So you can remember soft cervix is a good cervix. So Goodell's sign indicates that soft cervix is a pregnant cervix seen very early at 6th week. Then uterine sign. Uterine sign, one of them is Piscak's sign. Piscak's sign is when there is lateral implantation of the baby, then you will see asymmetrical uterine enrollment called as Piscak's sign. Hagar's sign. Hagar's sign is occurring because there is difference in the uterine consistency. Now this is the uterus with the baby implanted into it. So here the baby, that is why it is firm here, because the baby or G-sac is there. Cervix is comparatively firm. It is soft, but it is firm compared to the uterus, and the middle part is empty. So because of this different consistency in uterus, your fingers tend to insinuate in the mid of the uterus, but not above and below. This gives rise to the Hagar's sign. Palmer sign, when you do a bimanual examination, rhythmic contractions of uterus can be felt at 4 to 8 weeks. That is Palmer sign. A lot of named sign, but you have no option. You have to remember. Repeated questions have been asked on the signs of pregnancy. In second trimester, what starts happening? Quickening starts happening. So quickening starts at 18 weeks. Means the patient start having the fetal movement. That is quickening. Then cloasma on the face, breast changes, all those start happening. Abdomen signs start appearing. So in the early pregnancy, there were only pelvic signs. But now abdomen signs like linea nigra, stria, and Braxton Hicks contraction. So these contractions, Palmer sign, which you were feeling on bimanual palpation, you start appreciating them when you keep your hand on abdomen. So these are Braxton Hicks contractions which are not painful. And palpation of fetal parts also start happening. Active fetal movement starts happening at 20 weeks. Okay, that is the quickening, what I'm saying. External ballotment. Now the Likert starts increasing. So if you try to push the baby from one side, you can feel the baby movement on another hand. So that is the external ballotment. Internal ballotment, when the same ballotment when you do per vaginal examination bimanual, is at 16 to 28 weeks. At less than 16 weeks, baby is very small. At more than 28, baby is very large. So external ballotment is at 20 weeks, whereas internal is at 16 to 28 weeks. Okay. Fetal heart starts appearing at 20 weeks. So a doctor can listen to a fetal heart by stent at around 20 weeks. Okay, so a lot of things happen at 20 weeks. In the last trimester, now the baby is big enough. What happens? There is increase in frequency of micturition. Then at 38 weeks, there occurs engagement of the head. So head starts entering the pelvis, which gives like a relief kind of feel to the mother because the diaphragmatic pressure is removed. This gives rise to lightening, which occurs in last trimester. Fetal movements are more pronounced, Braxton Hicks are most pronounced. So all that happen in last trimester. Let's get back to the question. Osiander and Goodell sign at 8th week, yes. Internal ballotment, no. Internal ballotment is seen at 16 to 28 weeks. Then here engagement, it is a sign of 38 weeks. So it is not also there in early pregnancy. So your answer is A. Okay. Which of the following is a protein hormone secreted from placenta? LH, FSH, GnRH and HCG. So among them, so basically they all are protein hormones, but the protein hormone secreted by placenta exclusively by placenta is HCG. It's a glycoprotein hormone secreted by placenta. It has structural similarity to LH and FSH, but LH and FSH as such are not secreted from placenta. GnRH is still being secreted from placenta. So but GnRH is a steroid hormone, right? Okay. So yeah, let's discuss the so GnRH is a protein steroid hormone. That's what I want to check. No. So GnRH is not a steroid hormone. It is also a protein hormone. Sorry. It is also a protein hormone, but whether it is being secreted or not, that is not very sure. HCG is the one which is surely and exclusively being secreted from the placenta. Let's discuss the hormones secreted by placenta. These are the steroid hormones secreted. Estradiol, estriol. So pregnancy is a very hyperestrogenic state. So placenta secretes estrogen, high amount. It secretes large amount of progesterone. That is why pregnancy is a very quiescent, silent state because of progesterone. Then all the aldosterone, deoxycortisone and cortisol, they are also being secreted by placenta. The protein hormones are many. One of them, the most exclusively being secreted, most important is HCG. HCG secretion starts very early in pregnancy. As soon as the implantation starts, the HCG secretion starts, mainly by syncytiotrophoblasts, right? The highest level are seen at 8th to 10th week of pregnancy. After that, so if you make a graph, so HCG secretion is maximum at 8th to 10th week. At 8th to 10th week, it is maximum. Then it falls down to a lower level and it becomes static. So this is how HCG hormone level is there. Now, it is a sign of pregnancy. That's what you check in UPT. It doubles in every 2 days. Human placental lactogen, again a very important hormone. Its secretion amount relates with the placental size. So as the placental size keeps on increasing with pregnancy, HPL also keeps increasing. So the graph of human placental lactogen is like this. It keeps on increasing. Okay, and it is highest at term. So human placental lactogen is highest at term. Another role is it is anti-insulin. So it is a diabetogenic hormone. The main purpose is so that the glucose is not utilized in periphery and the glucose is available for the fetus. That is the purpose of this human placental lactogen. Then all these protein hormones, corticotropin releasing hormone, GnRH and thyrotropin growth hormone, they all are released in minor amount by the placenta. Important thing I want you to know about these hormones is that progesterone is being secreted in high amount by the placenta, but the precursor for the progesterone secretion comes from the mother. The precursor DHEA comes from the mother. That is how the placenta is able to secrete progesterone. Similarly, the precursor for estrogen is nothing but the fetal adrenal gland. So fetal adrenal gland is the main precursor for this high amount of estrogen. So these are two important things about hormones. Next, what are the steps of normal labor? Again, it is a very frequently asked question. The steps of labor, they are very important. So see, they are very basic. You don't have to rectify them. When labor starts, what thing happens first? First is the engagement. What is engagement? When your biparietal diameter crosses the pelvic inlet, that is engagement. So that engagement is your first step. Next is descent. Now descent is the first prerequisite. Descent has to happen continuously throughout the labor, then only the baby will come out, right? So it is the biggest prerequisite that should happen. In nullipara, engagement happens first, and when labor starts, descent start occurring. But in multipara, descent and engagement start together, right? So first is this, second is this. Now as soon as descent occurs, fetus reaches the pelvic floor. It encounters the pelvic floor muscles. As a result, because of those encountering that muscle, it flexes. So next is flexion. And why this flexion is occurring? So that the smallest diameter could come in the pelvis. Okay, so this flexion occurs. Now as soon as it flexes and enters further into the pelvis, on meeting the levator ani, what happened with contraction? Each contraction of levator ani tend to rotate the head. And how? It tend to bring the occiput of the baby behind the pubic symphysis. That's what levator ani tend to do. So what happened after flexion is internal rotation. Internal rotation, the purpose is to bring the occiput behind the pubic symphysis. That is what internal rotation is happening. Then after internal rotation, once it has happened, then happens crowning. So once it is crowning means that now it is out of, just at the pelvic floor. And after crowning, what happens? With another push, the baby delivers. As soon as it comes out, the force of that muscles is gone. So the flexed head extends. So after crowning, extension happen. Okay, the muscle resistance is gone, extension happen, and fetal head delivers by extension. Now as soon as fetal heads deliver by extension, we remember that when the internal rotation is happening, there is 1/8 twist at the neck. We know that there is 1/8 twist at the neck. So this untwisting of neck occurs. So untwisting of neck is occurring inside, but the head movement which you are seeing outside is nothing but the restitution. So restitution is occurring because 1/8 of the twist is there in the neck. To relieve that, restitution is happening. Now the neck twist is relieved. Now what happened? Now what will deliver? Now the shoulder come. Now shoulder, which was in transverse diameter, they rotate into anteroposterior. When they are rotating in anteroposterior, the fetal head is also moving. You can see fetal head moving. So this fetal head which is moving because of the shoulders rotating inside is external rotation. Okay. Once external rotation occur means the fetal shoulders have moved inside, the delivery of the shoulders occur. Okay, that is the steps. Simple. So these are the steps. They're easy. So let's see here. What will occur first? Restitution, crowning, external rotation, flexion. So first will be flexion, followed by crowning. Then the delivery. After delivery, what will happen first? Restitution, followed by external rotation. Right? So this is our answer. Okay, I hope I'm clear. Now identify the type of ovarian cancer from gross specimen, very frequently asked. So see, can you see this is a gross specimen with fat lobules and hair? So it is easy. Whenever there are multiple cell lineages are there, it is a case of teratoma. Mature or immature, that you cannot know, that you all will not get also. So this is mature cystic teratoma. Let's see other tumors and other commonly asked tumors. So serous, if a tumor is given which is bilateral, it has been given, it is solid and cystic both, solid cystic both, and a psammoma bodies is written on HPE. Okay, so then think of serous tumor. So serous is the most common epithelial tumor. Epithelial tumors are the most common invasive ovarian tumors. Among these epithelial tumors, serous is the most common, solid and cystic, bilateral, psammoma bodies on HPE. Okay. Mucinous is second most common, not second most common, is a kind of epithelial tumor. Okay. The typical feature is they are huge. They are huge, enormous. The question will give you they are enormous, filling the entire abdominal cavity. And there are multiple follicles. Can you see this gross semen? Multiple mucin filled follicles are there. So this is a mucinous tumor. Dysgerminoma. So that those two were epithelial tumors. This is a germ cell tumor. So dysgerminoma is a germ cell tumor. So what question will give you? Question will give you, first of all, age will not be high. It occurs in young women. So question will give you a young woman. She might be pregnant also. So it's the most common tumor occurring in a pregnant woman. So pregnant woman, and it is bosselated. Can you see it is bosselated? If you cut, it is fleshly, pale to tan brown in color. So on gross it is bosselated, and when you cut it, it is pale to tan gray in color. And they will give you young woman or a pregnant woman, and sometimes dysgenetic gonads. So you have learned that in XXY, in androgen insensitivity, or in Turner's X0XY, Turner mosaic, you have to remove the gonads because there is tendency to develop cancer. Which cancer? This is the cancer which develops in dysgenetic gonads. Okay. So this will be the history, and this will be the appearance in case that dysgerminoma is being asked. And it has been asked. So it is important to see dysgerminoma properly. It has been asked. Immature teratoma. So basically what is teratoma? When basically various elements start maturing, the mesodermal, ectodermal, a lot of elements start maturing together, it leads to teratoma. If they mature in a normal line, it gives rise to mature teratoma. If they does not mature in a proper way, it gives rise to an immature teratoma. Now mature teratoma is benign, immature is very invasive. So both occur in a young age. Okay, and grossly you will see when a specimen is given, you will see tooth, you will see hair, you can see fat cells. So you can see multiple cell lineages together in a young woman. Then you think of teratomas. Okay. Krukenberg might also be given to you. Krukenberg is the most common metastatic cancer. It is bilateral. The size is different, but they are very bosselated contour. Okay, asymmetrically enlarged and bosselated contour. Think of a Krukenberg tumor. They can also give you a sign of signet ring cells. So signet ring cells are a sign of Krukenberg tumor. Okay. So these specimens are the one which have been asked and which can be asked. Other tumors of ovarian cancer, they will not ask you because they are not differentiable on the gross specimen. Next, oral contraceptives provide protection against all the following. Easy. HIV, endometriosis, cancers, endometrial ovarian. So let's see. So HIV solves a lot of, besides contraception, they provide you a lot of menses related benefits, which is decrease blood loss, hence improve anemia, decrease dysmenorrhea, make your cycles regular. Besides that, it decreases the risk of PID. How? Because it makes your cervical mucus thick. That is why PID risk is decreased. I am not saying STDs. It does not work on STDs. It decreases pelvic inflammatory disease risk. Okay. Decrease ectopic pregnancy risk. Decrease ovarian cyst formation. It is even given in ovarian cyst. Decrease benign breast disease. Decrease acne. So in acne, OC pills are given. Okay. In IVF also, if you give 3 cycles of OCP, then when you start IVF, the response is much better. So they are increase the fertility after 3 cycles of OCP, decrease rheumatoid arthritis incidence, also treatment of endometriosis and fibroid. So these are the non-menses related. If you talk of cancer, it is good for ovarian cancer. It is even the only chemo prevention in ovarian cancer. Those who are at high risk, you give them OCPs. Okay. It is providing protection against endometrial cancer. So in endometrial hyperplasia, you give progesterones. Okay. So endometrial cancer, ovarian cancer, and also colon cancer. But it has no role against breast cancer, and it has no role against cervical cancer. In fact, in breast cancer patient, you do not give OCPs. Okay. So it provides protection against 3 cancers. Let's back to question. It provides protection against HIV and STDs? No, it does not. Endometriosis? Yes. Endometrial and ovarian cancer? Yes. A patient has been diagnosed as a case of mild anemia at 34 weeks. What intervention to be done as per guidelines of Anemia Mukt Bharat? So you should know about Anemia Mukt Bharat. It has 6x6x6 strategy, 6 beneficiaries, 6 interventions and 6 institutional involvements are there. 6 beneficiaries are typical children age 6 to 5 years, then adolescent girls, adolescent boys, both, then reproductive age women. So we do not want reproductive age men to be treated. Reproductive age women, pregnant women, lactating women. Okay, 1, 2, 3, 4, 5, 6. 6. Okay, children, all the children, adolescent age girl and boy, reproductive age women, pregnant women, lactating women. These are the beneficiaries which are being treated. The 6 interventions being done are that you provide prophylactic iron and folic acid to them. So these 6 interventions are done in all the 6 classes. How they are done is different for all the classes. Okay, dose and the frequency will be different for all. What we are most concerned is pregnant women and little bit of lactating women. So they provide prophylactic iron, folic acid, deworming, and then in behavior change. Like behavior change is delayed cord clamping is a part of it. In delayed cord clamping, more blood is going to the baby and the chances of anemia are decreasing. So intensifying the behavior, testing an anemia and treating, then provision of iron and folic acid fortified food. So now flours, wheat flours are coming with the fortification of iron and folic acid and addressing the non-iron, non-nutritional causes of anemia. So these are 6 interventions done in each of these 6 beneficiaries. So let's see what we are doing in the pregnant women. That's what is being asked. What intervention is done in case of mild anemia in them? So what they have told that in case of mild anemia, 10 to 10.9 is mild. 10 to 10.9 is mild. Then again, sorry, 7 to 9.9 is moderate. 5 to 7 is severe and less than 5 is very severe. Yeah. So how to treat? In case of mild anemia, they have clearly said that you have to treat with 2 tablets of iron and folic acid. Okay. 2 tablets means 1 tablet contains 60 mg elemental iron and 500 mcg of folic acid. So 2 tablets are given for the treatment in case of early pregnancy. It means in case of less than 34 weeks. That's what you will do. If she is in late pregnancy, or you have given this treatment and you repeat your hemoglobin after 1 month, because that's much time occur for hemoglobin to build. After 1 month there is no response, or she is in late pregnancy, you don't have time ki you give iron, then you repeat and you see the response. You don't have that time in late pregnancy. You straight away start with parental iron. Parental iron में IV iron, sucrose and carboxymaltose both are there. Okay, so Anemia Mukt Bharat recommend IV iron, sucrose and ferricarboxymaltose both. Okay, so in late pregnancy you will give this, or if the patient is not responding, okay, then you will give the IV iron. This is in case of mild anemia. Even in moderate anemia, again you will give the iron folic acid 2 tablets, but if she is in late pregnancy, she is more than equal to 34 weeks is late pregnancy, you will give straight away IV iron, but you do not give them together. IV and oral iron are not given together. Okay, in case of 5 to 7, you will, what you will do, you will straight away start with IV iron. Okay, you will straight away start with IV iron. In case of less than 5, you will admit the patient. Okay, this is the management according to Anemia Mukt Bharat. Now let's get back to the question. Oral supplementation with iron folic acid and IV sucrose? No, both are not given. IM ferricarboxymaltose is given at 34 weeks. Yes, this is your answer. 2 tablets of iron folic acid per day. If she would have been less than 34 weeks, then the answer would have been 2 tablets of iron folic acid per day. 3 tablets? No, it is not given. So if you can see here that parenteral iron means IV iron, sucrose or FCM may be considered as first line in pregnant women anemic late in the pregnancy. FCM can be given IM and IV both, right? Okay, so this is your answer. According to WHO, what is the minimum number of ANC visit? Why this has been added? Because according to the Indian guidelines, the minimum ANC visits needed is 4. According to old WHO, the minimum ANC visits was 4. But WHO has updated it and said that if the number of visits is 8, the pregnancy outcome is better. So minimum ANC visits according to WHO it has been asked, not according to Indian guidelines. It is the 8. Okay, so 8 visits are necessary as per the WHO. Next, muscles contributing to pelvic diaphragm are the following except. What is pelvic diaphragm? So pelvic diaphragm is basically a sheet of muscle in the pelvis which separate your pelvis from the perineum. So everything above this muscle constitute your pelvis, and when you come below this muscle, it is perineum. You talk about superficial perineal pouch, you talk about deep perineal pouch, everything below this sheet of muscle, which is pelvic diaphragm. How the pelvic diaphragm is formed? Majorly, the pelvic diaphragm is formed by the muscle called as levator ani. Levator ani originate from pubic symphysis, from this white line. This white line is on the obturator internus muscle, and from the ischial spine. From all these, a big sheet of muscle arise. Levator ani run medially and backwards, and it decussate in between. Okay, it encircles these vaginal hiatus and this rectal hiatus and provides support to them. So it runs between them, it decussates and it provides support. And it goes and attaches to the coccyx. So the mid-raphe is created here between coccyx to the rectum, called as anococcygeal raphe. Okay, so this muscle is spread all over the pelvis. Here, from here to here is the levator ani muscle. Now levator ani is such a big muscle, so it has been divided into different parts depending on from where it is being originated. So the part which is being originated from pubic symphysis is called as pubococcygeus. So pubococcygeus is a part of levator ani. Then one arising from the ilium. This is the white line on the ilium. Okay, is iliococcygeus, again part of levator ani. One arising from the ischial spine is ischiococcygis. So ischiococcygis, some consider it to be a part of levator ani, some consider that it is not part of levator ani, it is separate, and they call it coccygis. Now whether it is part of levator ani or not, it does form the pelvic diaphragm. This whole muscle sheet is pelvic diaphragm. So levator ani plus coccygis, you can say, is forming the pelvic diaphragm, right? And this muscle piriformis in the back, it is not forming the pelvic diaphragm. So everything above pelvic diaphragm is pelvis, everything below is the perineum, right? So if we see also the fibers which are decussating in between behind the rectum like this for providing the support, they are the puborectalis fibers. So puborectalis is nothing but again a part of levator ani. So pelvic diaphragm is being formed by levator ani plus coccygis, and levator ani is nothing but iliococcygeus, pubococcygeus, and puborectalis. Simple. Let's get back. Muscles contributing to pelvic diaphragm are levator ani. True. Pubococcygeus, yes. Iliococcygeus, yes. Obturator, no. Obturator is not. This muscle is obturator. It is not part of levator ani. Obturator is giving rise to a white line, which is giving rise to levator ani, which is the origin point of levator ani. But obturator internus is not pelvic diaphragm. Which of the following strain is used in HPV vaccine? So this is again a repeat question just asked, I think in 2020 it was asked. See, HPV genome give rise to multiple proteins. It give rise to 6 early proteins. 6 early proteins are E1 to E6. Okay, and 2 late proteins L1 and L2. L1 and L2 form the structure. They are the structural proteins, and they forms the genome. They are the genetic proteins. Now if you see the action of each of them, then L1, L2 are basically needed for initiation of infection. Okay, they are structural protein, they are needed for initiating the infection. Then E1, E2 are needed for the invasion. Okay, and then E6, E7 are the one which are actually responsible for malignant transformation. So malignant transformation is because of E6, E7. So this is the protein structure of HPV. Now when you are making a vaccine, what do? You use virus-like particles. So what do you use? You use structural proteins L1, L2, because now since they are the part of structure only, they are the empty shells which has no genetic material. So you use L1, L2 to create empty shells which are like virus, but genetic material is not there. So infection will not occur, but immune response will be there. So the vaccines, all the vaccines use L1, L2 to generate virus-like particles for producing the vaccines. Okay, so these are the prophylactic vaccines so that the infection does not occur. The work is undergoing for treatment of HPV. So those who have developed the HPV, so that they don't develop the malignant transformation, the therapeutic vaccines are being formed. Now, if the therapeutic vaccines will form, which protein they will use? This is the protein used for which was causing malignant transformation. So E6, E7 are being worked on for therapeutic vaccines. But currently, prophylactic vaccines are using L1 and L2. Now, what is true regarding cisplatin resistance and sensitivity? A very tough question. I just don't understand why they asked that from an undergraduate. Anyways, now they have asked, so we should know about it. So, basically, ovarian cancer, we have to use the chemotherapy. So, except for stage 1, early cancers, which they are called as early cancers with low grade stage 1 cancer, you just do this surgery and no chemo is needed. In rest all, after surgery, chemo has to be given. Okay, 6 cycles of chemo. In some patients, you will listen what is called as neoadjuvant chemo, in which if you see the tumor is very big or very big adhesions are there, it is not resectable, you give 3 cycles of chemo, then you do surgery and then you give remaining 3 cycles of chemo. So that is neoadjuvant chemo. But chemo has to be given in everyone stage 1 high grade and followed by other stages. You have to give the chemo. Now basically platinum based chemotherapy are given, cisplatin, and in those who are very old age and medically comorbid, you give carboplatin. So if you talk about resistance for the chemo, so what the NOVAC says exactly is, if a patient develops relapse within 6 months, you are giving the treatment, you have given the treatment, within 6 months the patient relapse. It means the patient was resistant to chemo. Okay, has relapsed so fast. If patient does relapse, but after 6 months, sorry, not within 6 months, but patient relapse after 6 months, it means it was sensitive. It relapsed, but after 6 months, so it means sensitive. In that case, the prognosis is better and you can again give a cisplatin based chemo. But here the prognosis is very bad and you have to think of some other agent. In case the patient is not responding while being on chemo, it is called as refractory to chemo. Okay, there's nothing like, in the whole NOVAC, there's nothing like partially sensitive. Okay, they use 3 terms: resistant, sensitive and refractory. So resistance is recurrence within 6 months, true. Within 6 months, it means it is resistant. So this is your right. Partial sensitivity is recurrent in 6 to 12 months, no, it's nothing true. Sensitivity is occurrence after 1 month, no, it is after 6 months. If the relapse occur, it is sensitive. Okay, so answer is only 1, right? Intrauterine growth of fetus is under the influence of following hormones except. So now basically this has been asked previously also, but it's a little tough question. The options were a little tough. So see, growth of fetus occur in 3 stages. So first 16 weeks is the time of cellular hyperplasia, when number of cells increase a lot. Then 16 to 32 weeks is the time of hypertrophy and hyperplasia, number increase and size increase. After 32 weeks is only the size increase. It is the time when maximum fat accumulation occur. It is the time when the maximum fetal weight gain occur. Okay, fetal weight increase after 32 weeks. So these 3 steps are involved in fetal growth. Now the hormones involved in fetal growth are, so whenever you study about the fetal growth hormone, the most important hormones always mentioned are insulin and insulin-like growth factors. They are the prime hormones responsible for fetal growth. Insulin and insulin-like growth hormones. Another hormone which is being mentioned is the leptin hormone. Leptin hormone is basically from the adipocytes of the fetus and it is responsible for the fat accumulation in fetus. So it is very important for fetal growth. Next hormone which is always mentioned in fetal growth is the steroids, corticosteroids. So corticosteroids are hormones basically not only for growth, they prepare your fetus for the coming into outer world, prepare for outer survival. So they grow and specialize the fetus for the outer survival. So they also play very important role. In fact, if the corticosteroid is in excess, they can impair the fetal growth also. So remember, when the lady is pregnant, you ask them to calm down, don't take more stress, because if she takes stress, the stress hormones, corticosteroids are released and they can very well cause IUGR, right? So that is why women has to be relaxed, because corticosteroids, if in excess, can cause IUGR, but they should not be low because they prepare the fetus for better growth, for better survival. Okay, another hormone responsible for fetal growth is growth hormone. So growth hormone has also been seen. It is involved in fetal growth from the ovulation to implantation to the last of the trimester. So it is involved in whole of the journey of the fetus. So these are the important hormones which are responsible for fetal growth. Glucagon as such has not been seen for the fetal growth responsible. Main work is it provide sufficient, it prepare the fetus for, in case hypoglycemia fetus faces, it prepares the fetus for hypoglycemia, but it has no role in fetal growth. Okay, so these were the main hormones responsible. Corticosteroid is responsible for growth, but also for lung maturation and thymus and GI. So corticosteroid is so important for lung maturation, for thymus maturation, for GIT. It is all the role of corticosteroid. So if we go back to our question, intrauterine growth is influenced by insulin, yes. Glucagon, no. Growth hormone and glucocorticoids, yes. Okay. What is vaginitis utrinus? Vaginitis utrinus is nothing but very rare incidence if found. It is cry of the fetus inside the uterus, okay, before delivery. Which of the following statement is true about perimortem CS? So perimortem CS is important. Perimortem CS is a case of CPR, is a step of CPR in a pregnant woman. So if in case of maternal collapse, when you see the steps of CPR, you try the CPR for 4 minutes. So maternal collapse has occurred, you try the CPR for 4 minutes. Now, since after 20 weeks, after 24 weeks, the diaphragm and IVC are being pressed by the uterus. That is why CPR measures are not very effective in a mother because of compression of the uterus. So when you start the CPR, you should always see that there has to be lateral shift in the mother. You have to shift the uterus or you have to shift the mother so that you can relieve the compression. Okay, to relieve the IVC compression, a lateral shift should be given to the mother. Okay, now the thing is ki if after 4 minutes of CPR, you are trying CPR for 4 minutes, nothing happened, you have to do a perimortem CS. So perimortem CS you are doing so that your CPR could be effective, right? So CPR recommendation according to OCG should be done within 4 to 5 minutes. Means after 4 minutes of, sorry, not CPR, perimortem CS. Perimortem CS. For first 4 minutes you are doing CPR. If the patient does not respond after 4 minutes, before the patient reaches the 5th minute, so within this 1 minute duration, you do a perimortem CS. So it's a very fast CS. You do it where the patient has collapsed. It is not done in OT. You want to do it fast, so you do it by a vertical incision from xiphisternum to the pubic symphysis. You make a big incision. On uterus again you make a vertical incision. It has to be very fast and you deliver the baby. Okay, then you start the CPR again. Now if the CPR has been successful, then you give a layered sutures, uterotonics. But if the CPR has not been successful, you just close the wound and you declare the patient has not survived. Okay, all these consent and the techniques and the OT are ignored. Okay, this is the perimortem CS. This is the time limit. Okay, 4 to 5 minutes means after 4 minutes it is done, but before 5 minutes within this 1 minute interval. Go back. So true statement is done through phalangeal incision, no. Done via upper uterine segment, true. Done via lower uterine segment, no. Done in OT, no. Okay. Now, which of the following method is not used in first trimester of pregnancy termination? Now, this is very important. Now, WHO has recently again modified its abortion care guidelines of 2022. They are so recent. So, I have got through this question a chance to discuss them also. So, we are discussing first trimester termination option. So, first termination option could be medical or surgical. Now, medical option in less than 12 weeks, what WHO says, this recent one is give mifepristone. On first day give mifepristone. After 24 hours give her misoprostol. This less than 12 weeks. Misoprostol can be given vaginal, sublingual, buccal, any route, single dose 800 mcg, right, by any route. If the pregnancy is more than 12 weeks, you will give mifepristone again 200 mg. After 24 hours gap is must. You will give meso. But this time you will not give single dose. The pregnancy is large. You will give 400 meso, okay, and you will repeat it 3 hourly, right? Route can be again buccal, sublingual or vaginal, right? In case it's a missed abortion, it is same. At less than 12 weeks, more than 12 weeks, it is same, except that since it is missed, the pregnancy might be smaller. The meso does not need to be repeated 3 hourly. Meso can be repeated 4 to 6 hourly. Otherwise, everything is same. This is same, this is same, right? Do you understand? Getting my point? So, medical, MIFI, followed by single dose meso, more than 12 weeks, MIFI, meso, repeat every 3 hours. In case of surgical, so it says at less than 12 weeks, vacuum aspiration, manual or electrical vacuum aspiration. At more than 12 weeks, DNC and evacuation, dilation and evacuation. These are the only 2 methods told by WHO. Preparation before these surgical methods could be by meso, MIFI or osmotic dilators. If you are using MIFI, you have to prepare 24 hours prior. If you are giving meso, then if you are giving sublingual meso, you have to give 1 to 2 hours prior the procedure. If you are giving meso vaginal, then you have to give 3 to 4 hours prior. So, sublingual is a very effective dose, no? So, if you are preparing the patient for DNE, you can give sublingual meso 1 to 2 hours prior to procedure. Vaginal 3 to 4 hours. If you are giving MIFI, 24 hours. So, for prep, any of these could be used at any gestation. But if she is less than 12 weeks, vacuum aspiration is used. If she is more than 12 weeks, dilation and evacuation is used. Right? So, these are the new changes by 2022 guidelines. What other changes are there? The WHO said that medical abortion at less than 12 weeks can be advised by the person himself. The patient can himself take this kit and get herself aborted at home. It can be by pharmacist also. So it doesn't need to be a medical person. But if medical abortion is being done after 12 weeks, it has to be done by a medical personnel only. Okay, so this is new thing, that if patients does not want any medical personnel to interfere and she is less than 12 weeks, she can herself use these kits. Okay, and a pharmacist can also advise. Another change was that antibiotic prophylaxis, that all the surgical abortion less than 12 weeks or more than 12 weeks, you have to give a single dose of antibiotic. You have to give. And all the medical abortion, you do not need an antibiotic. So this was another thing. Then about anti-D, what new thing was there in anti-D? All the medical and surgical abortion at less than 12 weeks, no anti-D is needed. This is introduced new. You will not give anti-D whether it is medical, whether it is surgical at less than 12 weeks. Now what will be followed by our practitioner, that is different, but this is what WHO says. Okay, so this is our answer. Now the option asks one more thing, installation of ethacrynic acid. Now these things were not even mentioned in WHO guidelines. But last year, question on the CAC guideline, clinical abortion care guideline, was asked. So CAC care does mention these substances. It says that in second trimester, the other substances like ethacrynic acid and hypertonic saline and oxytocin can be used, but they are not safe. This was mentioned in CAC guideline. So ethacrynic acid is actually a method in second trimester, not the first. So this is our answer. So mifepristone and meso can be used. Manual aspiration according to CAC guidelines. So manual aspiration, we have seen that, according to CAC and WHO both, at less than 12 weeks, manual vacuum aspiration is a choice. So that can be done. Misoprostol alone can also be used in the abortion. If you are not using MIFO, you are using meso, that's okay, but the efficacy is less. Another which new drug was introduced in this guideline is, instead of MIFI, you can give letrozole. Yes. So I am just telling you because I am doubting that this question could be asked. Letrozole with misoprostol after 3 days is another method for medical abortion. Okay, this is also recently updated in 2022. Okay, right. So the question, so you kindly just copy this table so that you just all the information which was there in this new guideline, I have collected it at one place. Okay, next. Pregnant lady has been taking SSRI depression. Baby can suffer from which of the following complications? So it is on teratology. Another question has been asked on teratogen. So it's important to read teratology in detail. Now, due to SSRIs, what can happen? Low Apgar score. ADHD, mental retardation, or pulmonary hypertension. So SSRIs are not contraindicated in pregnancy. Okay, they are safe except for paroxetine. So paroxetine is the one which is not recommended because they can cause ASD and VSD. It is the only one which is not recommended in pregnancy. Rest or SSRI are safe except they cause little neonatal symptoms which include hypotonia, jitteriness, and respiratory depression. So respiratory depression leading to low Apgar does occur, but it is mild and occurs only for 2 days. One very commonly linked problem that can occur with SSRI is persistent pulmonary hypertension. This persistent pulmonary hypertension can occur with SSRI, due to which there is right to left shift, okay, in the heart. As a result, there will be hypoxemia and low Apgar score. So these are the only 2 mild complications that can occur with SSRI. So your answer is 1 and 4. It does not have any neuronal side effects. So it can be safely used in the safest use medications, psychotic medications in pregnancy. Okay. Now, non-immune hydrops fetalis is seen in all. So causes of hydrops fetalis could be non-immune and immune. So non-immune causes and immune causes. Non-immune causes are the most common cause of hydrops fetalis. First thing. So now hydrops fetalis most common causes are non-immune, in which most common are the cardiac anomalies. So cardiac congenital anomalies, not the mother. Cardiac congenital anomalies are the most common cause of non-immune hydrops. Besides that, all trisomy 18, 13 and 21 are also cause of non-immune hydrops fetalis. If you talk about immune, it is by infections. So basically which infections? Parvovirus infection, torch infection, toxoplasma, rubella, cytomegalo, herpes, syphilis infection. They all can cause immune hydrops fetalis. HIV does not cause your hydrops fetalis, right? Okay. Which of the following is not a risk factor for vulval carcinoma? So let's study the vulval carcinoma. So risk factors for vulval carcinoma. Now vulval carcinoma is increasingly becoming a little common. So the questions are also being asked on it. Initially it was not that common. It is a cancer of postmenopausal age group. The risk factors are HPV infection, lichen sclerosis, smoking, immunocompromised, vulval intraepithelial neoplasia, and chronic inflammatory dermatosis. They are very important. There are 6, you have to remember them. So they all are risk factors for vulval cancer. Now the vulval cancer seen in older patient is more common, but it is not generally HPV related. It is generally seen around the lichen. So women, if you will see a case of vulval cancer, you will see that she was having lichen sclerosis, which eventually evolved to vulval cancer. Whereas young vulval cancer is HPV related and it is not HPV related. And it is occurring in those who smoke and are immunocompromised. Okay, right? So this is the about vulval cancer. Let's get back. HPV, it is a risk factor. Smoking, vulval hematoma. No, vulval hematoma is not a risk factor for vulval cancer. Lichen sclerosis is a risk factor. Patient visit to you with 36 weeks of pregnancy and absent fetal movement. On ultrasound, image was seen. She was, so image, I don't remember what it was, but as per recall, it was the gas in the great vessels. So gas in the great vessels as a sign of IUD, it's an early sign of IUD, is Robert sign. So let's see other signs. So what will you see in case of an IUD baby? Absent fetal heart, absent fetal movements. Then you will see the Robert sign, which is seen in less than 12 hours. Robert sign is the presence of gas in the great vessels and the fetal heart. When the gas is seen in umbilical vessels, it is helix sign. Okay. A late sign is overlapping of skull bones. So skull bones tend to overlap like this. So it is Spalding sign. Okay, it's a late sign. Then ball sign means hyperflexion of the baby, the spine of the baby, leading to ball sign. Crowding of rib shadows is also there. Okay, remember these signs. DES in pregnancy increase the risk of which? Okay, what is DES? Diethylstilbestrol. Basically, it is nothing but it is a synthetic estrogen. So this was formed because it was used in pregnancy because it used to prevent all the cases of preterm, cases of excessive nausea and vomiting. All those were prevented by DES, and it was glorified as a very wonder drug. But eventually it was seen that DES was causing a lot of problems in the babies. In women, the DES can increase the risk of adenocarcinoma of vagina. Adenocarcinoma of vagina was increased by DES. Okay, it was slightly increased. It's seen that cervical changes were also brought up by this drug. What changes? That the transformation zone size was increased. Cervical collar was being formed. As a result, chances of cancer were more. It was not causing cancer, but the chances of cancer increase in women exposed to DES. Then the T-shaped abnormalities of uterus causing infertility and preterm delivery were also caused by DES. Okay. Then in males, if you talk of what happened in males, basically testicular abnormality leading to infertility, okay, was happening due to DES. Okay, this testicular abnormality was happening. So these were the consequences of DES, which is what it was withdrawn from the market. The breast cancer risk, no, breast cancer risk initially was thought that they are causing breast cancer, but it was in the end found out that it was not at all related to breast cancer. It was related to adenocarcinoma of vagina and slight increase in risk of cervical cancer. So this is your answer. Okay. Vulval carcinoma is seen in which age group? Okay, very good question. Now, so please take a pic of this slide if you can, because I have collected all the cancers with their respective age group. So endometrial cancer is seen at 60 to 70 years. Okay, majority of cancers are seen at more than 50 years. So average age is 60 to 70 years, and majority of cancers occur in the women who are over 50. Cervical cancer has a bimodal representation. They peak at 35 to 39 and the second peak is 60 to 64. Okay, so these are the two peaks for cervical cancer. Ovarian cancers could be of three types. Epithelial cancer is a cancer of postmenopausal age group in 60 years. Borderline tumors are basically adolescent, 45, not adolescent, like of adult, 45 years. Germ cell tumors are tumors of a young woman. So germ cell, most common germ cell dysgerminoma is typically seen at 10 to 30 years. Other germ cells like teratomas seen even at younger age, at less than 20 years. So germ cells are tumors of younger women. Granulosa cells like thecoma, fibroma are again of postmenopausal age group. Okay, vulval cancer is of 65 years age. Okay, so please take a picture of this. I have collected from everywhere the age groups of these cancers. Which among the following is wrong about late decelerations? Okay, they are smooth and gradual. They start after uterine contraction start and end after contraction ends. Fall in heart rate is more than 10 to 20 beats. Okay, not followed by acceleration. So let's see the deceleration. So different type of decelerations can occur on a CTG, either early, late or variable. Now what is late deceleration? So see here, so this symmetrically, so this is late deceleration. This gradual decrease and a gradual rise, and from start to this peak, this duration is 30 seconds. In late deceleration, important is that they start after the contraction has started. They peak after the peak has attained, and they end. This is the end of the contraction. They end once the contraction is ended. So they are following the contraction. They are not simultaneous with the contraction. Whereas similar features, gradual fall, gradual rise, this from start to the peak is 30 seconds. But starting with the contraction, peaking with the contraction, ending with the contraction is early deceleration. Okay, it is after the contraction. Important that in early deceleration, generally the heart rate does not fall below 100 to 110. From the baseline, it hardly follows less than 10 to 20 beats per minute. Late deceleration fall only 20 to 30 beats per minute from the baseline. So fall is not that much, a little more than early, but not that much. Early deceleration is because of head compression, right? It is not pathological. But late deceleration is basically because of uterine or the fetal hypoperfusion. So it is a sign of hypoperfusion. The most common cause of late deceleration are the epidural. If you have given epidural suddenly, the patient has hypotension, as a result hypoperfusion occurs, late deceleration starts appearing. Also, if you are inducing the patient and oxytocin is being given, uterus starts hypercontracting, then also late deceleration starts happening. So these are the very two common causes of late deceleration. Also, it is a sign of chronic fetal hypoxia. Variable deceleration is the one it is the most common deceleration, first of all. So there is abrupt decrease, there is no gradual decrease, abrupt decrease. Fall is more than 15 beats for more than 15 seconds, but less than 2 minutes. Why less than 2 minutes? Because if fall is for more than 2 minutes, if it's such a big fall, it is prolonged deceleration. It is not variable. It is prolonged deceleration. Okay. So more than 15 seconds, but less than 2 minutes. Their onset, peak and recovery might be related to contraction, but in every contraction it is different. It is not same in every contraction. So it is variable with every contraction. Okay. Now they can be preceded and followed by acceleration. That can happen that it will fall and then acceleration will occur. But the late deceleration is not followed by acceleration. It returns to the baseline, but acceleration does not happen. In variable deceleration, see, it returns to the baseline and acceleration happens. This is called as shouldering. So shoulders form. Okay. When it is preceded and ended by the acceleration, the shouldering occurs in variable deceleration. That does not occur in late deceleration. Okay. Now, so let's get back to the question. They are smooth and gradual, correct. Start after the contraction start and end after the contraction, correct. Fall in heart rate is more than 10 to 20 beats, not followed by acceleration. So, fall in heart rate basically is not more than, you will say, 20 to 30 beats. So, it is very close. It means basic purpose is that fall in heart rate is not very much. So this is not right. So fall in heart rate is not more than 10 to 20 beats. It is not followed by acceleration. That is true. Okay. So this is the best answer we can say. Yeah. Identify the feature which correctly describe the following CTG tracing. Now what we can see fetal heart, we can see contraction. Is it a late deceleration? It looks like after contraction the deceleration is occurring. Good. It is a non-stress tracing. See, what is CTG and what is NST? NST is a non-stress test. You are just trying to see whether the fetus is in stress or not. Patient is not in labor. You are just trying to see that whether there is chronic hypoxia or not. So what do you see? You just see fetal heart rate and you see accelerations are there with fetal movement or not. So if with the fetal movement acceleration is occurring, it means the fetal is in a very good condition. If it is not occurring, it doesn't mean that fetus is hypoxic, but you have to test further. So NST is a non-stress test. You do not look for contractions. Why? Because contractions are not there. It is done in antenatal period. In high risk pregnancy, you do NST. Okay, in antenatal patient. Though you see for acceleration with fetal movement. CTG is done in labor. You are trying to see the changes in fetal heart with each contraction. What is CTG? Cardiotocography. Cardio means fetal heart. Toco means contractions. The graph telling about the heart and the contraction is CTG. Okay. It is a non-stress tracing. No. The contractions are there. It's in labor. It's not a non-stress testing. Beat to beat variability is not normal. So yes, this is correct. So no, beat to beat variability is normal. What is beat to beat variability? It is if you exclude the accelerations and the decelerations, the difference between the maximum trough and the peak is your variability. So remove the acceleration, but in this if you subtract the accelerations and the deceleration, you should get a difference of 5 to 15 beats per minute. That is a normal beat to beat variability. So here it is normal. So your answer is it's a late deceleration. Okay. Match the following. Another question on the fetal toxicology. Sorry, not toxicology, the teratology. Match the following: warfarin, thalidomide, lithium, chloramphenicol. See, warfarin cause depressed nasal bridge, thalidomide cause phocomelia, lithium cause abstinence anomaly, chloramphenicol Krabbe syndrome. Now warfarin does cause depressed nasal bridge. That is why warfarin is not advised in the pregnancy except for in patients of mechanical heart valves. Those who have mechanical heart valves, in them low dose of warfarin, less than 5 mg a day, is allowed because it causes a low nasal bridge. Okay, that is why warfarin is not given. Whenever a patient thrombosis risk is there, you prefer heparin, except in mechanical heart valve. Okay. Then thalidomide. Thalidomide is a category X drug, extremely not given. It causes dysgenesis of long bone leading to phocomelia. Okay. Lithium is again not advised in pregnancy. Lithium can, in early pregnancy, it can give rise to Epstein anomaly. Epstein anomaly means there occurs the uplifting of the tricuspid valve tricuspid valve uplifting. As a result, there is severe tricuspid regurgitation which occurs. So it is not given in early pregnancy. Even when given in late pregnancy, lithium will not cause upstream anomaly. If it is given near term, it can lead to diabetes insipidus. It can lead to thyroid abnormalities. So it is again not given in near term also. Chloramphenicol can lead to grey baby syndrome. It's an antibiotic which can lead to grey baby syndrome. Other teratogens which you should know about is alcohol can lead to fetal alcohol syndrome. In fetal alcohol syndrome, there is abnormal CNS development, all the central structures. So there is nasal hypoplasia, the philtrum is not formed, vermilion is small. So it is caused by fetal alcohol syndrome, abnormal CNS development. Okay. Then you have to know about alcohol syndrome. Doxycycline is again another contraindicated antibiotic because of the browning and discoloration of the teeth and dysgenesis, abnormal development of the bones. So it is also not given. Then the anti-seizure drug. Anti-seizure drug can lead to fetal Hydantoin syndrome. Question has been asked on it. Fetal Hydantoin syndrome mainly caused by phenytoin or sometimes by carbamazepine. Fetal Hydantoin syndrome, in which there is hypoplasia of fingers, microcephaly, short palpebral fissures. Short palpebral fissures is also called in fetal alcohol syndrome. So fetal alcohol syndrome, Hydantoin syndrome you should know, doxycycline you should know. Yeah, so these are the teratogens you should know about which are not at all used in pregnancy. Yeah. Now what is the wrong statement related to calculation of a period of gestation? It is calculated from the last day of LMP. No, it is calculated from the first day of LMP. So this is our wrong option. In first trimester, CRL is the best assessment? Yes. In the first trimester, especially from 11 to 14 weeks, the CRL is the best assessment for a period of gestation. In IVF date, ET is needed to calculate it to POG. ET is embryo transfer. Yes, in IVF, the periods, when will the periods have come, is not important. Important is when the embryo was transferred. So you will calculate it from the embryo transfer day by adding 266 days, that is 38 weeks. So here you calculate in a normal patient 40 weeks, but here 38 weeks because the 2 weeks, initial 2 weeks when the embryo is formed are not calculated because you are calculating it from embryo transfer. So initial 2 weeks are subtracted, you add 266 days. Each trimester is made of 14 weeks. Yes. So each trimester, whenever you read from any book, each trimester is made of 12 to 14 weeks. It's not 12 weeks. 12 to 14 weeks is each trimester. Why? So 40 weeks is the term, okay, and 40 to 40 weeks is late term. So it's not post term, it's late term. Beyond 42 weeks is post term. Beyond 42 weeks is post term. No. So if every trimester is 14 weeks, so 42 weeks is approximately term, right? Everything beyond 42 weeks is post term. So that is why each trimester is calculated, is ranging from 12 to 14 weeks. It's not fixed at 14 weeks, at 12 weeks, right? So this is also a right answer, okay? Correct sequence for performing DNC, very easy. How will you perform a dilatation and curettage? First, you will dilate, curate, sound the uterus or assessment of uterine size. First, you will always assess the uterine size. You will see the position, whether it is anteverted or retroverted. This is your first step. Then you will sound the uterus to see the uterocervical length. Before sounding, you want to know the uterine position, because if it is a retroverted uterus, you will just go and poke the anterior wall and cause the perforation. So you will first see the position and then you will sound the uterus. After sounding, you will do the dilatation, and after the dilatation, next step is the curettage, right? This is easy. Identify the option which correctly describe the given procedure. So the image as per the students was not very clear, but there was an ultrasound probe and the needle. So if it was the condition, then this is the case of amniocentesis. Amniocentesis, which, and here in the table the options, other options were given. So one matches with this. It is done at 19 to 20 weeks. So let's see the other options. So this, when you see a speculum and a catheter going to the placenta, then it is a case of, and ultrasound probe is there. Ultrasound probe, you will need ultrasound probe to see where your catheter is going. But if it is done vaginally into the placenta, sometimes you can see a catheter going into the placenta abdominally also, because chorionic villus sampling can be done anyways. It is a case of chorionic villus sampling. You are taking chorionic villi. Here, A scope is introduced into the fetal skull and you are introducing a catheter. What is this? It is fetal blood sampling. Okay, it is fetal blood sampling. Okay, using a scope. When there is an ultrasound and you are inserting needle into the cord, what it is? It is chordocentesis. Chordocentesis you are doing in case of RH incompatibility, right? So it is chordocentesis. Now here it is a catheter. Again you need an ultrasound. It's a catheter. No, you will not need a ultrasound. Sorry, this catheter will have a camera to visualize where you are going. It's like an endoscope, and you are going inside the fetus. It is nothing but fetoscopy. You are trying to see inside the fetus, and fetoscopy is also used for therapeutic procedures, like if you want to do certain surgeries while the baby is in the womb, then also fetoscopy is used. Okay, so this going into chroniculized CVS. This is fetal blood sampling. This is chordocentesis when it is going into cord, and this into fetus is fetoscopy. Okay, right. So this was all about the INICET exam. I hope I have covered all the questions. If anything is missing, you can put in the comment box. I'll definitely give the answer to you. And just prepare well. Be focused. Remember, this is the time. If you will not lose your hope and you will just keep working, consistency is the key to success. So if you will just keep working, you will definitely be successful in your next endeavor. Okay, so study well. If you have any question, just let me know. Bye bye.